the study that I'll be discussing has lot of ramification in the clinical practice. In fact, lot of us are doing it, but we did not have any robust data. Now, for the first time, we are having some data in a prospective setting that tells us that what we are doing. Anyway, I can tell you everybody is doing on some patient or the other, but this is the first prospective study to say or to prove what we are doing is in fact right. So the study that I am discussing today is a optimal sequencing of enzalutamide and abiraterone acetate plus prednisolone in metastatic castrate-resistant prostate cancer, a multicentric, randomized, open-label, phase 2 crossover trial. Now, this was published online in the November edition in Lancet. So basically, again, an open-label phase 2 crossover trial done at 6 centers in British Columbia, Canada. Now, to understand the importance of this study, let us understand two things. All of us know that abiraterone as a first-line treatment in metastatic castrate-resistant prostate cancer, we have a phase 3 data, COW 302. Again, with enzalutamide, we have a phase 3 data, that is a PREVAIL study. Both studies showed that this drug improves radiographic progression-free survival and overall survival. But we don't have any study which is direct head-on between abiraterone and enzalutamide. So you can use any of the two, but you don't have any prospective study to study that. The second most important thing is, if you have used abiraterone, can you use enzalutamide or vice versa? Now, basically, there is no robust data. There are 3 retrospective studies which has been conducted. 2 studies gave enzalutamide as the first and abiraterone as the second line. The PFS response was less than 10%, dismal response. The third retrospective study used abiraterone first and then enzalutamide, also had a limited response. But again, all 3 were small retrospective studies. So as a practice, we do it, but we did not any robust data. And that formed the basis of this study. So it was the first randomized head-to-head comparison of abiraterone plus prednisolone versus enzalutamide in metastatic castrate-resistant prostate cancer, first prospective. And the second most important thing is, does sequence matter? So this trial also compared best treatment sequence and is there a second line activity of any or both the drugs. So all newly diagnosed prostate adenocarcinoma without neuroendocrine differentiation with a castrate level of testosterone with rising PSA were included in 2 arms. So group A had abiraterone followed by enzalutamide. So abiraterone 1000 mg once daily with prednisolone given till confirmed PSA progression or any radiotherapy given, unacceptable toxicity or withdrawal. Around 101 patients. Once they progressed, they were given enzalutamide. So A was Abi followed by enzalutamide. In the group B, it was the other way around. So they started with enzalutamide and on progression gave abiraterone. Now, when you look into the primary endpoint of the study, it was like a PFS2. So the primary endpoint was start of the treatment to time to second PSA progression. So you gave a treatment, on progression gave the second line treatment, and when they progress, what is this time? And the second primary endpoint was a PSA response more than 30% decline on second line therapy. So they wanted to look whether second line really improved the PSA response. Now, when you look into the results of the study, first time to from the start of first line therapy to second PSA progression, and what they observed was for those patients who are given abiraterone first followed by enzalutamide has a better PFS2. So the PFS2 improved from 15.2 to 19.3 with the absolute gain of 4.1 months when Abi was followed by enzalutamide rather than other way around. So the first trial, there is definitely importance in significance. So the second primary endpoint was there a PSA decline during second line therapy? So when you look into it, in group A, the second line drug was enzalutamide. So when enzalutamide was given in a second line, there was 36% patient who had a PSA decline of more than 30 versus only 4% when abiraterone was given in a second line. What about overall survival? So in group A, there was a numerical improvement in overall survival from 24.7 months to 28.8 months. So there was again a 4.1 months improvement in OS, which was numerically important, but statistically not significant. Now let us look at the secondary analysis. Look at the right side of the curve first. Suppose if you use enzalutamide as a first line or abiraterone as a first line, so no added advantage. You can use both the drug in the first line with the time to PSA progression is around 11 months. But what is more important is if you are using enzalutamide as a second line from abiraterone, the PFS response is 3.5 months, whereas it is only 1.7 months when you are using abiraterone in the second line. And this is statistically significant with a very significant hazard ratio of 0.42. What about PSA decline during first line? So first line in those patients where enzalutamide was used had a 82% of patients had PSA decline versus 68% in abiraterone. So although the time to PSA progression is equal, but suppose if you want to give only one drug, then enzalutamide, more patients will have a PSA response as compared to abiraterone. Now coming to side effect, does side effect matter? So there were serious side effects in 15% of patients in group A, that is Abi followed by Enza, versus 20%. But these were minor and there was no treatment related serious adverse events. So in terms of toxicity, it is equivalent. Now, what is the reason why enzalutamide is working in the second line and why abiraterone is not working in the second line? So what they suggested is, once you give the drug, there are mutations involving the ligand binding domain of the androgen receptor that we know that emerge during the course of this therapy. Now, when you look into abiraterone with prednisolone, there are two common mutations that come, L702H and 7T7878A. And in both the mutation, enzalutamide retains androgen receptor inhibitor activity. So once you give abiraterone, there is a mutation, they are still sensitive to enzalutamide. Whereas when you are giving enzalutamide, there is a amplification of the androgen receptor, and here abiraterone is also resistant. So the resistant mechanism is not overcome by abiraterone. So what they concluded is time to second PSA progression was better for the sequence of abiraterone followed by enzalutamide, driven by the second line activity of enzalutamide. There is no difference in time to first PSA progression. So if you are using a single drug, you can use any of the two. But enzalutamide retains clinical activity as a second line drug following abiraterone, whereas abiraterone retains no single line activity following enzalutamide. Of course, what Sahu sir discussed and everybody, you have other drugs also. So because of this modest response to second line enzalutamide, you have other available appropriate options that you can try when the patient is progressing on first line androgen receptor pathway inhibitors like taxanes and radium. But this result for the first time in a prospective supports the role of enzalutamide as a second line androgen receptor pathway inhibitor, but not for abiraterone. So last itis clinical implication, this is my take. Definitely all of you have patients who have never taken any of these tablets and sensitive because they are with urologists and you have never seen them. Now they are coming to you in your clinical practice and you will see a subset of patients who will not desire to take a IV chemo, or you may not think that he may tolerate IV chemo. So if in a real life situation, if the patient is not fit for IV chemo or is non-willing for the same, in order to maximize the best use of the available resources you have, choose sequence of abiraterone followed by enzalutamide for better overall survival, better PFS2, and this is the first and the only randomized study which is available till now in a prospective setting. I thank you all for a patient hearing.